Alright guys, so this is JD. I'm here for a little Heme Week 1 review. Um, Disclaimer, this may not help you for boards, this may not help you for summatives. It's alright. So let's jump right in because I have to break these up into only 15-minute chunks, so not a lot of time. I'll try to make it pretty quick hitting, but you'll get the PowerPoint, so you can always study that as well. So erythropoiesis requires growth factors, mainly EPO, but in three basic vitamins and minerals: iron, folate, B12. Um, Mnemonic there, IFB, I feed blood, is also the order in which they are absorbed in the duodenum, jejunum, and ileum, IFB. Um, Real blood cells are obviously composed of heme, which is porphyrias, which we'll talk about, and iron, protein and lipid membranes, but eventually push out their nucleus and don't have mitochondria in their final stage as well. So basically they rely on glucose oxidation for energy and the hexose monophosphate chunk to reduce the iron from 3 plus to 2 plus, which is the usable form that binds to oxygen. So prenatally, as you can see in this bottom right corner, we have hematopoiesis. So first, blood is produced in the yolk sac, and that gradually transitions to the liver and spleen. At birth, however, it's pretty much entirely transitioned to bone marrow. So clinical significance in disorders like torch infections or other newborn anemias, the liver and the spleen still have to um, perform hematopoiesis, so you get extramedullary outside the medulla of the bone marrow. Hematopoiesis, you can also get that on the skin as well, which is kind of the blueberry muffin spots that you see in torch infections. So that's important to know. You have a timeline as well, a little mnemonic that helps you. Young liver synthesizes blood, yolk sac, liver, spleen, and bone marrow. Postnatally, the bone marrow that produces red blood cells is mostly in the axillary skeleton as well. This is just a little outline of how EPO works in the kidney to stimulate the bone marrow to increase red blood cell mass, which increases oxygen delivery to the kidney. So then that kind of has a feedback loop to shut off the EPO. So erythropoiesis, there are different kinds of hemoglobin. So when you're mainly still in the womb, the liver and the spleen mainly produce this gamma hemoglobin. So that replaces the beta chain, so you get hemoglobin F towards birth. And through infancy, you have more of the beta chain. So in disorders of the beta chain, like beta thalassemia and sickle cell disease, in the newborn period, you're kind of protected because you mostly have these gamma chains, which are normally a pretty small percentage as adults, but they're a much larger percentage when you're born. Hemoglobin A2 is caused by the delta chains, which are just produced at low levels throughout life, but those are going to be proportionally increased in beta thalassemias as well. And we'll talk about that later. So a brief review of growth factors. I'm not going to read this table for you, but EPO is an important one to know, produced in the interstitial cells of the kidney. I will add particularly high yield to that. Increases red blood cell production, hemoglobin F production, mainly used in CKD. Medicare will pay for it when the hemoglobin is below 10, I believe, as well as other anemias, chronic anemias, malignancy, aplastic anemia, etc. GCSF for granulocytes is also used neutropenia, post-chemo, when you're trying to get their counts back up. It's also used when you donate stem cells peripherally. They can give you a bunch of GCSF, causes your bone marrow to go nuts and churn out a bunch of precursor cells, which you can harvest from your blood, actually, using apheresis, and so you don't have to get a bone marrow needle. IL-5 stimulates eosinophils. Memorize that part. Use anti-IL-5 antibody in asthma. That's the clinical significance of it, but I don't think anything else there's much to know. Thrombopoietin is mainly produced by the liver. That's why in cirrhotics you often see, it's one of the reasons in cirrhotics why you can see decreased platelet count. It's constituted in the liver. It can also be produced in the bone marrow as well. So synthetic Thrombopoietin agonists like eltrombopag can be used in ITP, marrow failure, and some of these others like IL-6 and IL-11 are actually synergistic with thrombopoietin to help produce platelets. I wouldn't worry too much about what those GCSF and IL-6 are produced by. So let's talk about the maturation process, which occurs in the bone marrow. So as you go down this, a nice mnemonic is pro baseball players ordinarily read ESPN. There are others that are probably better, but that's the one I use. So basically, as the red blood cell matures in the marrow, you get a cytoplasm that goes from this dark blue color up here down to this more grayish and then gradually pink, like an erythrocyte. The nucleus gradually shrinks, the RNA content decreases, it kind of becomes darker and darker and then disappears. So in the reticulocytes, you just kind of see these little RNA remnants. The cell also shrinks as well. It's a lot smaller as a fully mature red blood cell. And as this whole process is going, the erythrocyte bag is just filling up with hemoglobin. So you max out your hemoglobin content and it's spit out into the circulation. Reticulocytes, we talked about, immature red blood cells. You normally see a few of them in circulation, about 3%. It's normally expressed as a retic count as a percentage, but you can get an absolute retic count too. And that can be important if the patient is extremely anemic. You need to look at the absolute retic count. For example, if you had, say, 100 red blood cells, and normally you have 3 immature red blood cells, reticulocytes, then that's like a 3%. So that's normal. So if you're severely anemic, say you only had a hemoglobin of 8, so 50 red blood cells, then that retic count would look like 6%. It would look like it was really high. But really, the bone marrow hasn't responded appropriately. It still has the same retic count, despite the fact that you're severely anemic. So instead, you need to correct it. So basically, you need to multiply the retic count by the hematocrit divided by 45. So basically, you compare the what a normal hematocrit is, 45, to what yours is now. So bilirubin metabolism, I linked to another YouTube video that's pretty good. There's a lot of them you can find online, from Khan Academy, etc., that do a better job than I do. But in a nutshell, red blood cells are broken down in the spleen by macrophages, forming unconjugated bilirubin. Insoluble, has to be bound to albumin, taken by the bloodstream to the liver through the portal system. It gets conjugated to make it water soluble so you can spit it out in bile. So it goes through the gut, and gut bacteria form urobilinogen, and that's broken. And then eventually gets broken down into the brown stercobilin in the feces. And a small portion of it gets absorbed back into the enterohepatic circulation, and a very small percent of it gets eventually secreted in the urine. Heme synthesis, so another big topic. Kind of briefly hit the high points for all the porphyrias and anemias here. So sideroblastic, I have some nice mnemonics here for you guys. Sideroblastic synthase, I'm trying to remember these enzymes. So sideroblastic produces anemia, not really a porphyria, because it's the first step. It's before you really have formed any of these porphyrins, so you don't really get the same side effects that you do for other things. And that can be that's an X-linked disorder, but it can also be related to a deficiency of B6 from meds or alcoholism or something like that. Lead poisoning. So kind of the classic presentation is a kid in an old house who is eating lead paint or something like that. You can get abdominal pain, you can get anemia, you can get some other symptoms. You can get these lead lines on the gingiva and the teeth, in kids. You can also get lines on the bone that are visible on X-ray. So I remember dehydratase is the heavy metals. Again, trying to memorize that enzyme. Lead poisoning can also affect ferrochelatase as well, which is, you can get like these neuropathies as well because you have a protoporphyrin buildup. AIP, so that's kind of the classic porphyria. if you're in class, you saw the Scrubs clip. So you get abdominal pain. You have these really strange polyneuropathies. Patients I saw had often been to multiple neurologists trying to figure out what's the cause of it, and you have the classic dark urine. So that's going to be porphobilinogen deaminase, so AIP deaminase, and PCT. That's the photosensitivity associated with Hep C, and it's decarboxylase, so that's a nice PCT, a little mnemonic there as well. So remember the decarboxylase is a PCT. You don't really get the neuropathies or other things that you get with the AIP, but it's the association with liver disease can pop up in step 1 as well. So basics of morphology. I just put this chart in there for you all to reference, so you can pause it and look at that. All important stuff that you need to know the names of, but I would just point out that target cells. So you can see target cells on pretty much or on a lot of smears. The important thing is when there's a bunch of them. So you can find that in hemoglobin C disease, asplenia, liver disease, and thalassemia is going to be the main one. And HALT is kind of the mnemonic they have in step 1 or in first aid. So again, here's just a chart. In the notes, it shows basically the answer to these, but just to familiarize with these smears. What a normal smear looks like. You can see a target cell here, actually. It kind of looks like a target cell. That's a normal smear. You can still get those. Here you see some variation in size. So anesicytosis, poikilocytosis, variation in shape as well. And it looks like maybe a burr cell there, but all looks weird, maybe thalassemia. Here you can see definite target cells that are very clear. Here you can see some, looks like maybe dicryocytes. You get the kind of this tear-shaped, like they're being squeezed out of the bone marrow, myelofibrosis, sickle cells, elliptocytes. Looks like some schistocytes here. They're cut off. Acanthocytes, they're a little spiny. And finally, burr cells. And I think there's stomatocytes over here too. You can see the little stoma mouth. Again, step to memorize what these looks like. So basically, Heinz versus Howell-Jolly. The important thing is Howell-Jolly show up on just your basic smears as a DNA inclusion. So usually the spleen is important in removing these little chunks, and if you don't have a spleen, then that's going to be why. And so that's just on a normal right stain. Heinz bodies, if you do a special supravital stain like a methylene blue, then you can see these better because they're hemoglobin. So, I mean, if you did a right stain, it'll look red like hemoglobin. So you can see it better if you use a different stain. And that's going to be if it's denatured by some sort of, not having enough of those, reducing agents. So when you have G6PD deficiency or oxidant drugs, you can get those. And you can just reference the rest of these, but that's the kind of the big things that you need to differentiate between. Oh man, so this is going to be our next slide, but you've got some high yield stuff going on here. Dr. Sitar in particular thinks it's high yield. So basically this is how to classify the anemias, and I'll go through this in detail in the next presentation, but we'll look at the microcytic anemias. So basically when you have less hemoglobin produced in the red blood cells, we'll look at the normocytic anemias, which can be either hemolytic or non-hemolytic, and the macrocytic anemias. So that's when you have kind of a maturation delay, like something's wrong with the nutrients. You're not getting the nutrients for whatever reason, so like folate and B12. So think of nutritional things. You can also get non-megaloblastic anemias that are not, or the macrocytic anemias that are non-megaloblastic, excuse me. So that's liver disease and alcoholism. So briefly about those. So that's when you have some sort of defect in membrane production, like alcoholism, which can lead to B12 and folate deficiency, but that's not. But when you don't have those, you just have alcoholism.